Hi all, Socrates Medicine, welcome back for another high yield ethics video. Content that is high yield for your board examinations and in-house tests. So we'll start off with a question, and you can review from the previous part 1 ethics video. A 41-year-old female with a rapidly progressive neurological disease has become so disabled that she's bound to the hospital bed. She's unable to live a meaningful life the way she had previously intended. She has pulled out her gastric tube and refuses reinsertion. Your colleague, a fourth-year medical student, suggests reinsertion of the NG tube. What should you tell your colleague? A. Insert the gastric tube. B. Rule out depression and insert the gastric tube. C. Rule out depression and respect the patient's wishes. D. Call the patient's family and discuss reinsertion of the gastric tube. Or E. Place an order for nutritional services to visit the patient at bedside. So, you want to make sure the patient does not have depression, and if that is the case, you must respect the patient's wishes ultimately, even if that means she would get severely sick or pass away. Patients have the autonomy to make the wrong decision, and in this case, C is the correct answer. Very straightforward. Physician suicide, it's always a physician-assisted suicide is always the wrong answer on examinations, and same thing with euthanasia. In terms of medical records and charting errors, so a patient always can obtain a copy of their medical records. One, you need an informed consent from the patient stating they would like a copy of their medical records, and you also need to take into consideration that even if it's a private practice, or regardless of how much their balance due is, they are still able to obtain a copy of their medical record, and nobody has the right to disrupt that. Not the receptionist, not the physician, not insurance companies for whatever reason. They have the ability to get a copy of their medical records. And then if you're still dealing with paper charts, if a physician needs to rectify a note, draw a line through the error and initial with the new date. So let's talk about malpractice. This is a very important topic, not just for questions and examinations, but also life. So in order for malpractice to occur, you have to have a deviation of care, and this includes things like not informing the patient of all the treatment options, and there has to be a poor outcome. So deviation of care and a poor outcome for the patient. And this is unrelated to how nice the surgeon is or how mean the pediatrician is. Just because someone's nice or mean does not give grounds for liability, okay? So you may see, depending on the literature you read, how, more physicians that are nice have an increased correlation of being less sued. That doesn't matter. That's unrelated to malpractice, okay? Malpractice, for it to occur, there has to be a deviation of care and a poor outcome of the patient. So I made these scenarios for you, and we'll discuss them and figure out whether or not malpractice has occurred. So let's say you have a patient and you garnered informed consent, and she is a rheumatoid arthritis patient, and you're treating her with methotrexate. She is upset. She developed several infections due to overt bone marrow suppression, so she decides to sue. Did malpractice occur? So in this case, actually it did not occur, because you gave informed consent. Just because there's an adverse event or complication from the treatment, that's unfortunate, but it is not grounds for malpractice. You did not deviate from the standard of care because you appropriately informed her of all of her decisions of treatment, risks, benefits, and lack of treatment by gaining informed consent. Next scenario is you have a patient come into the ER with dysuria or painful urination. She denies any past medical history. She does not inform you of her G6PD deficiency diagnosis, nor of her strong family history. There's no previous medical record in the hospital. You start her on Bactrim. She later develops a severe hemolytic anemia. What do you think? Did malpractice occur or not? So again, in this case, this is an interesting scenario, and I think they may try to trick you with this. Just as we need to inform the patient about all of their risks, benefits of treatment, no treatment, alternatives to treatment, procedures, just as we are informing them of the whole picture and all of their options, the patient needs to inform us of their medical history. And in this case, because the patient did not inform her physician of her past medical history of a G6PD deficiency, the physician didn't have enough information to or change his treatment practice or change her treatment for this patient in this scenario. So there's no malpractice if the patient has not informed the physician of their past medical history. And the physician had no way of knowing, right? Because you looked them up in the hospital records, there was nothing. She never said anything about family history. She never said anything about her past medical history. So in this case, malpractice did not occur. And again, malpractice, get this in your head, it's a deviation of care, and there has to be a poor outcome for the patient. Doctor-patient relationship is obviously sacred. And even though we are trained, and rising physicians are trained to, prevent suffering and harm and these type of things that drew you ultimately to being a doctor, right? The physician must agree to accept a patient. There's no legal obligation to enter into a doctor-patient relationship, okay? And I wanted to address the Good Samaritan law versus emergency services because the physician acts in two different ways and is protected in two different ways here. So the Good Samaritan law, this basically protects any caregiver from liability if they are trying to aid a sick or aid a trauma patient, right? It does not force the physician to aid an injured patient. However, if you act in good faith and there's a car collision and you're making the best judgments and things like that, you're not liable. However, the moment that you step into an emergency room and you are a physician staffed in a hospital, you cannot turn away anyone at the door of the ER if a patient comes in seeking care. And so in this case, for emergency services and in the emergency department, and the ER is not responsibility for the continuity of care after discharge. But there is a national legal mandated mandate essentially for all hospitals to provide emergency management and treatment of all patients. Small gifts are appropriate, but not if the patient has expectations in return. So that, if they want a different medication or discounted copay, right? That's what we're kind of getting at there. And then this goes without saying, but it needs to be said, physicians cannot have romantic relationship with patients. Again, one of the most honorable things about being a physician is the strong morals that physicians uphold and how we are held to such a high standard to give great care to our patients. And this is obviously crossing the line in terms of professionalism. You can't have a romantic relationship with the patient. If the physician is in a romantic relationship with the patient, they must end their doctor-patient relationship immediately if they want to continue in the romantic relationship. And then just a little tidbit there, the American Psychiatric Association, they have guidelines that state that there can never be a intimate or romantic private relationship between a doctor and a patient, even after the professional relationship has ended. So just be on the lookout for that in terms of your in-house exams and board questions. So arguably one of the most high yield slides of this presentation would be the abuse, child abuse, elder abuse, and spouse abuse. Now, As long as these reports are in good faith, you are protected. A physician is protected as a mandated reporter. And ultimately, you want to report child abuse regardless of what the parent says or what the parent wants. And you're going to report that to Child Protective Services. For elder abuse, report to Adult Protective Services. Now, the question could be a tricky situation for spouse abuse, because you don't want to overstep too much, because it's a tricky situation, because the victim is scared that they're unable to leave the relationship or unable to report their partner or significant other. And so in this case, the answer would be you want to encourage the patient to report or offer counseling. Okay? And then as we increase the amount of physicians, increasing the amount of medical students through our medical education, we have more and more physicians that are becoming military physicians. And that's wonderful. And thank you all for that. I've chosen to do that. And whether it's domestic or overseas, you need to be ready for any sort of question that puts you in a military or prison situation. And so ethically, physicians cannot participate in executions, and that's because it's in stark opposition to the duty to preserve life. Ethically, doctors have to relieve suffering and to protect life, and this surpasses the ability to participate in any sort of execution, okay? Physicians cannot participate in torture. You may see torture described in a question stem with something basically along the lines of harmful interrogations, and ultimately physicians must report and oppose elder abuse, child abuse, spouse abuse, and also torture. You are allowed to treat, or a physician is allowed to treat, those who have been injured by torture once the person has been removed from that area in which they were being tortured, which that makes sense, right? Because you don't want to treat somebody who's being tortured only for them to improve just enough to continue to be tortured. That's just wrong, right? And so those are two pretty straightforward answers, but they're weird, right? And they're tricky, and you may see those show up. And then lastly, you want to always report gunshot wounds, even if the patient objects, because this is another big instance where the safety of the greater community, not just the hospital, not just the ER, but the greater community supersedes that of the patient who does or does not want the gunshot wound. This is a very up and coming topic, I think, and I think it needs special attention as you move forward in your board exam. So we need to talk about impaired physicians, and that includes, the classic substance abuse, being drunk. It also includes psychiatric disorders and Alzheimer's disease. So we want to approach these scenarios, and I've made this little table here. You want to report to the local answer choice, or whoever's in the next in line of the hierarchy, right? Because we in the medical system, we have this hierarchy. So what you may see is, say the MS4 is coming to the rotation high, for example. And so the appropriate person you would report to would be the medical school dean or course director. Say an intern or resident was in a drunken stupor and, they're at the hospital taking care of patients. You would report that to the program director or department chair. Let's say you had a really busy day at the hospital and you're rounding and you're just patient overload is you're carrying a bunch of patients in your notes, and you're spending a long time and you're there late and your attending is starting to sundown. That would be reported to the department chair or division head. And then lastly, the private practice, that's the one instance where you would report to the state board of medical conduct or health or the educational department. The only other thing I want to add about this is maybe your resident and your co-resident is with you and he or she went to the lake for the weekend and was partying and very drunk and intoxicated and made poor decisions. you don't report that unless that resident shows up and it's now interfering with the patient care. He's in the hospital, he's making poor decisions, intoxicated with patients, and that's when you would report. So just because he goes on the weekend to the lake, that's not reportable. But the moment it starts interfering with patients and the quality of their care, that's when you step in and report to the program director or department chair. And then also doctor-doctor disputes. I can see this getting bigger on board questions and in-house examinations as well. Is very straightforward. The attending disagrees with the intern. Well, obviously the attending has the authority to overrule. And let's say the intern disagrees with the attending. The answer choice they're looking for would be like discuss with the attending or collaborate or work together to resolve the issue or come to agreement, that type of. Lastly, I want to speak about research. So in order for a participant to enter into research or clinical trial, you must garner informed consent. They need to understand the risks and benefits. That's pretty apparent. And it needs to be voluntary. It needs to be on their own free will. They're not being forced into participating in a randomized controlled trial, for example. And one way I think they could try to trip you up here is if they present a scenario where it's a prisoner. And you need to remember that in terms of research, the prisoner has the same rights, voluntary, free will to enter into the study. They can withdraw at any time. They can refuse to enter into it. And they also need informed consent. So that's pretty much it. Reach out if you have any questions. Otherwise, I think you're good to go for your upcoming board exams. Reach out if you have questions, like I said. And I look forward to seeing you all soon. All right. Thanks. Bye.